So I want to thank you all again for joining us. And we will start now, and hopefully those who come in late can pick up wherever we are. Again, I welcome you to our webinar today. And the discussion, as I said, is on maternal mental health, effective scalable interventions for low resource areas. My name is Paul Mosley. I'm currently country director for the Mennonite Central Committee in Ethiopia and a co-chair of the CCIH working group on the health of women and children. If you're new to CCIH, if you're not familiar with the organization, Christian Connections in International Health, it is an international network of approximately 115 Christian organizations and 15 secular partners, as well as a few hundred individual members. CCIH's mission is to promote health and wholeness from a Christian perspective and provides opportunities for capacity building, networking, sharing best practices, and advocacy. And by way of background on the selection of this topic by the Health of Women and Children Working Group, we have been engaged in the past year and a half on identifying the Christian space, that is the place where churches and faith-based organizations has the moral authority and leverage to improve health outcomes for mothers and children. As you all know, maternal and child health is a very broad field, but we identified in the last year and a half the issue of respectful maternity care as an excellent opportunity for our faith-based partners to engage in improving the health of women and their children. Since then, we've expanded our focus on respectful care to look for opportunities to find effective ways to address maternal mental health during pregnancy and during early childhood development, particularly in low resource settings. There is a growing body of research showing the effect of maternal mental health on health outcomes for infants and children, including childhood development, growth, that's height and weight, breastfeeding, care seeking for childhood illnesses, rate of childhood illnesses, and even child mortality. With this in mind, we invite you all to engage with us on this topic with the help of our distinguished speaker. Let me just quickly go over the logistics for this particular session, and then I'll introduce Ms. Koyiet. So the flow of this webinar, we will hear from our speaker, and then we'll have time for questions. Please use the Q&A box on Zoom to type in your questions. You should see that on the bottom of your screen, a Q&A box that you can click on. We'll answer them after our speaker presents. Please feel free to post your questions when you think of them, but we'll hear the presentation first before opening up the Q&A. This webinar is being recorded and will be posted on the CCIH YouTube channel and linked on the mental health section under resources on the CCIH website. So let me go ahead and introduce to you Phiona Naserian Koyiet, Senior Technical Advisor for Mental Health and Psychological Support, Global Rapid Response Team at World Vision International. Phiona Naserian Koyiet is a mental health and gender expert with over 15 years of experience in development in fragile and crisis contexts. She also has 4 years clinical experience in a hospital setup and HIV/AIDS comprehensive care center. Ms. Koyiet provides technical input to MHPSS programs in fragile and crisis contexts. She leads mental health and psychological support strategies and approaches for World Vision International's Global Rapid Response Team. Ms. Koyiet holds a Bachelor of Arts degree with a double major in Psychology and Community Development from Daystar University, Nairobi, a Master's of Art in Gender and Development from University of Nairobi. With that, I would like to hand over the microphone to Phiona Koyiet. Welcome.
Thank you, Paul, and welcome everyone to our webinar today, and thanks for joining. It's my pleasure to share my experience on World Vision, mental health, effective, scalable psychological intervention for low resource setting, or which we have implemented in fragile contexts. Next slide. And I would like to begin by just what you already know about the data of maternal child mental health. You all know how important it is to actually address maternal and child mental health as early as possible if we are to actually make sustainable development, or if we are to save a generation, then we need to begin from maternal and child health. Also looking at the data where 10% of pregnant women and 13% of women who have just given birth experience a mental disorder, and primarily depression, which in most cases is undiagnosed or untreated, or access to care is not even available in most settings. And these are not just figures for low resource setting, and not just a problem for industrial countries, because we do know from data or from research that have been carried before that approximately between 15 to 16% of women actually in developing countries do suffer depression or maternal depression during pregnancy, and about 19.8% after childbirth. This data might look really small because we are not talking about 50%. To some people, they say maybe this is not significant, but you might realize that behind the data, there is a child, there is a mother, and for every case of depression, 3 other more people are affected. So when you have one person diagnosed with a mental condition, then 3 other people around them are affected. And we do know postnatal depression particularly has a lot of significant negative impact on breastfeeding and also on child development. And from data, we also know that 2.5 of mothers, approximately mothers with depressive symptoms have a higher, 2.2 higher odds of being stranded than infants of mothers who have few symptoms. And we will look at effective treatment globally. In other research, we know that about 40 or 60% of people who actually go to a health facility do complain of mental health issues, but it goes untreated or undiagnosed. And that has not changed how the treatment is effective. For those who have a diagnosed mental disorder, about 76% and 80% of people in low and middle income countries who have a diagnosable or a treatable mental condition do not get treatment and do not access treatment, either because it's not available or it is not easily accessible in that setting. And so people are treated for other things, but not necessarily a mental health condition. And when we talk about maternal and child mental health, particularly affecting mothers, depression is quite significant because that's becoming a major issue, particularly targeting or affecting most mothers. And we also know that mental health or maternal mental health disorders are treatable. They are actually treatable. The whole idea is, how do we ensure that we scale up care so that people can actually access care, so that we don't have 76 or 85% of people needing care not accessing care. Next slide, please. And looking at that, maternal and mental health are links to newborn health. And we will not forget how just having a mother who is experiencing violence in a household, how is a mother who is just exposed to a lot of adversity capacity during pregnancy and during birth, and while taking care of the infant, increasing anxiety, is also putting vulnerability to an already vulnerable group, that they are not able to take care of their children anymore, they are not able to take care of themselves. And this affects definitely the child or the infant at those early ages. And this had linked to preterm birth, low weight, low birth weight, high rates of diarrhea diseases, early cessation of breastfeeding, undernutrition in the first year of life, and higher rates of stunning. And not forgetting that mothers, when they are going through this adversity, they are not even able to ensure completion of recommended immunization. In any case, most mothers are blamed to be not caring, not not being responsible when these issues occur. And that's why it is still poses a challenge. And that's why most countries, you find, they still have suicide as a death penalty when somebody either attempts or somebody either try to take their own life. So the stigma associated to being ill in itself is actually another additional pressure for a mother who is already experiencing depression or symptoms of depression. Next slide, talking about suicide, because when we look at suicide, an average adult, we are looking at the ages of 15 to 59. And when WHO has actually talked about 79 of global suicide occurring in low and middle income countries. And when every attempt of suicide happen in this low resource setting, and every year, way before COVID, which has just made life more complicated and added an already existing pressure and exposure to adversity, 800,000 people die every year because of suicide. And particularly suicide is interesting considering that we also have adolescent mothers or young mothers, and of course the children. And when we know that around the world, 20% of world children and adolescents have a mental condition. And suicide is the second leading cause of death among the 15 to 29 years of age. So you can imagine how the data look like when you already have an adolescent mother in that category. And 17% of the youth in low and middle income country attempt suicide, according to the last Lancet report. And suicide continuously remains a public health concern that is not dealt with, yet we know that you can actually prevent suicide and you can address suicide in a timely manner using evidence-based psychological intervention, which are scalable, and they're actually low in terms of cost. Because the general stigma around mental health, people think that you must have a psychologist, you have to have a psychiatrist for you to be able to address this. But there is still more that we can do, or we can partner with local communities like faith leaders to be able to prevent suicide and other mental health conditions. And looking at caregivers' mental health and psychosocial support in our next slide, based on previous research that have been conducted, there has been a lot of evidence that actually having or combining maternal and child health programming in our regular programming, where we are doing nutrition, or you're doing food security, or you're doing livelihood, has much more benefits on the children and the mother. And it has more benefit on the development of a child than perhaps implementing a single programming. Supporting parents, building parent skill on positive parenting actually has a long way in benefits in terms of the child and the mother. And supporting mothers who have diagnosable mental condition, or building their capacity to be able to address their concerns or their issues so that they can be able to care for their children and themselves has long-term benefits than doing single programming. Because you can provide your nutrition, you can provide your food, but if you do not address the mental health issues, then your food has no full benefit of the child. You're just giving like half a spoon of an intervention, and which does not cost you much just to have an integrated programming. Next slide. And caregivers' mental health and psychosocial support. When we talk about caregivers' mental health, what do we actually mean, or what are we trying to improve? Because when you look at caregiver mental health, we are talking about therapy, where you have a parent experiencing depression. As we have mentioned, depression is a major thing among it. Pregnant women or mothers who have just given birth. And therapy has a lot of impact in addressing depression, for example, or just the exposure to adversity, because this will improve the cognitive development of a child. Because when a mother is during pregnancy, they are already communicating to the child. If they are living in an environment exposed to violence or severe level of adversity, and they are being hopeless, they are communicating to the child. When we target parents or mothers during pregnancy and after pregnancy, we also ensure that we increase coverage of vaccination, because the mother is looking forward to care for their child. They are not feeling hopeless. They are not losing the morale or the courage to care for their children because they are functioning well. And then we will also reduce episodes of diarrhea. We will have good participation in play activities by both parents, because it is both beneficial to the parent and the child. There is a lot of impact when a parent plays with a child and they have a lasting relationship. It enhances their mental well-being. And many mental health conditions can be effectively be treated, or even suicide can be prevented. And we know from many research that depression, you can still afford to actually manage depression in low resource setting without using clinically trained staffing. And just to share a few examples of World Vision, what do we do in mental health and psychosocial support in World Vision in the next slide? And so World Vision acknowledges that mental health is definitely a critical and important subject and is core in addressing poverty, communities exposed to adversity in fragile contexts, as a holistic well-being. Because you cannot have a single well-being. You need a holistic well-being. And children and caregivers are at the center of our work. And we know violence, particularly exposure to adversity, and multiple risks actually come along with mental health problems. And World Vision is a member of the Interagency Standing Committee for Mental Health, the ISC. We actually use the ISC guideline in our mental health programming. And we refer much to what many people know as the mental health intervention pyramid, which look at various points from the basic needs as access points to mental health, to community and family support, to focus and non-specialized support, to specialized services. Because we do believe that there are people who will actually need to get proper treatment for their mental disorder, where they have to see a psychiatric doctor or they have to see a professionally trained professional. But we know that we start from the access point, where we look at how do we enhance community and family systems to be able to implement mental health. In the next slide, as World Vision, we have actually contributed to many global guidelines. as an effort to actually ensure that we use our field experience and we use our expertise to bring change to community intervention or low intensity intervention, because we believe they are scalable and they can be implemented in different settings. And World Vision, in partnership with WHO and the ISC, has tested various tools. And just to give an example in these slides of what World Vision has done. And under WHO, the mental health intervention guidelines, we did this initial trial and the write-up where we try to explore how do you integrate mental health intervention even within the primary health care, where we do have those services. So our programming have run where we actually have services in partnership with government, and also where we work in fragile contexts, and how do we partner with communities to still realize that the 78 to the 80% who actually need care are actually cared for. Next slide. As a Christian organization, our first stop is, of course, is the faith. And I just want to ask, based on your own interpretation, do you see faith MHPSS as a stopgap or a long-term partnership? We do know that the faith leaders do exist in this community way before we went in there. There is a lot of study how important and how faith has actually played a critical role in enhancing people's psychosocial well-being, because they believe or they're looking forward and being hopeful to the faith of someone has a lot to do with their recovery. And in fact, people who have strong faith in their belief system, in their religion, tend to recover faster, even when you're providing treatment. And so our first stop always is, we did come in and partnered with others to get to develop a faith-sensitive approach in humanitarian response, which is a guidance to mental health and psychosocial programming. And World Vision has its long-standing using of channels of hope for faith leaders, which is the foundation of our work, which aims to actually challenge the approaches that faith leaders use and empower them to be more proactive to include their community. And if you're addressing FGM, gender, child protection, it actually builds their capacity to be able to rally this protection mechanism within their faith teams, or within their churches, within their mosques, or within their religious grouping. Because faith approaches actually provide the experience in providing service. So we don't need to struggle to reinvent the wheel, but even as we consider community structures, the faith leaders already provide that expertise. And we just need to maximize community impact through responsive to faith identities. Because generally when people experience adversity, when they go through difficult moments, they go to their faith leaders. Majority of community members look up to their faith leaders. Hence, this will actually capitalize along long-term sustainable presence, because they do have the presence, they do have the access to the communities. And when we want to discuss issues around stigma, they are better placed to facilitate dialogue around stigma, access to care, and actually encourage community to access their care. And also building on the legitimacy in the eyes of the beneficiary of communities, because these are their own. They understand the custom, they understand the faith. And when we target them for MHPSS programming, then you're safer. And World Vision is a standard practice where we use the channels of hope. We go further and just train our faith leaders on psychological first aid, which is basically the first line of response on how to serve people in a humane way. It does not mean they do not serve people in a humane way, but just to acknowledge that, you know, having suicide ideation or suicide attempts It does not mean that you're actually separated from your God. It does not mean you've done anything wrong. But this is a condition. It's sickness, just the same way somebody would have diabetes and would have cancer. And of course, we enforce the inclusive social values and best practice that the faith leaders already have in their teaching or in their practice. And this will only be good to us as implementers because we will have a more comprehensive, effective way of programming by including faith leaders. And as World Vision, we ensure even when we have psychological intervention, we try and see, look out, who is the community health worker who is also a faith leader, is practicing faith in their own right? Are they part of the people we are targeting? So as we use any psychological intervention, we always try and look out, what is their space if we are doing this? Where do they come in? How do we also include them in programming as our first stop and as a sustainability way of actually working with the faith community? Now, I would like to share in our next slide and in my next presentation, two psychological interventions World Vision has tested in partnership with WHO and has actually been able to prove effective. And one is Problem Management Plus, where we actually tested the individual intervention. The group Problem Management Plus was tested much later last year and was published. And I want to actually refer to Problem Management Plus, which is delivered in groups, that was tested in Kenya and Pakistan in my next slide. Problem Management Plus, as the name is, in the next slide, it was tested in Pakistan and in Kenya. These were two different contexts in partnership with WHO and others. And in both FCT, it showed PM Plus was effective in reducing symptoms of depression, anxiety, post-traumatic stress disorder, and improving functioning. In Kenya, we actually tested PM Plus amongst women, and these women had a history of gender-based violence. But we did not screen them for gender-based violence, but these issues came out of our research. They actually, 80% of the women had experienced gender-based violence. In both studies, we found that PM Plus was effective in addressing depression, anxiety, and post-traumatic stress disorder. And maybe what you will be interested to know, particularly how it relates to our topic today on maternal and child mental health, is we had several cases or several clients. And one in particular that is still our case study is a mother that we enrolled in our study when she was 3 months pregnant. And she said, I have actually lost my pregnancy like 5 times. I'm currently having high blood pressure. I have tried everything, but I'm not able to carry my pregnancy to term. And I just wonder if this intervention will help me in any way. And I really want to try it out because my husband is still there and he's still looking for, but he told me if I lose this pregnancy again, that will be it. And you cannot believe it. We just encourage her to enroll in PM Plus and use the strategy to the end. And by the time we were finishing our study, she was able to carry her pregnancy to term and even reduce her high blood pressure tablet intake. And she was able to deliver. As we speak, she is a mother of 4 children and she has continuously used PM Plus, and especially the stress management skills, which I will show you in the next slide, because PM Plus is a simple intervention. It has 5 key sessions. The strategies are 4, which are managing stress, managing problems, get going, keep doing, which is the most interesting because it deals with the mood and the emotions someone is having at the moment. strengthening social support, and of course, staying well and looking forward. PM Plus is an intervention. The plus is the additional cognitive interventional therapy that were added in the usual problem-solving intervention. And Problem Management Plus is implemented over 5 sessions. Each session is approximately 90 minutes, and it is done over a period of 5 weeks. So you only give one intervention per week. And PM Plus aims to build the client's capacity to manage future problems or what they are going through. So this is not like the usual contemporary counseling that we normally have, but PM Plus actually builds a client capacity. When they go through the intervention, you don't need to reinvent the wheel again, because from the clinical trials that we've seen and implementation that we've seen, even 3-6 months after, the client can still use the intervention, because the staying well and looking forward session support the client to prevent future relapse. And so PM Plus on its own, after we did the trial and it was done in Kenya, World Vision Kenya went ahead to try and explore, is this something can be integrated within the Ministry of Health usual programming? Is it something that the Ministry of Health perhaps can integrate? Because in our study, we had worked with the community health workers. And so we moved into Kenya to try and run the pilot study. In our next slide, if I can summarize, in the study, we work with some districts in Kenya, about 4, Nairobi included, and we integrated PM Plus from the policy level and try and train from the Ministry of Health, and then let them cascade the training as usual, the way they do business as usual. And they would train the district staff, and then the district staff or the county staff would actually train community health volunteers their usual programming and integrate it within the system. And over 5,000 individuals were identified with common mental health problems, and they received PM Plus in less than 6 months. This was actually big because of the time frame it took, and this was purely implemented by the Ministry of Health. So what I want to say in the next slide is that PM Plus, it's possible to embed PM Plus in any health system, as we see in Kenya in the next slide, where we came up with a strategy which the Ministry of Health embedded and took it over as part of their programming. Now, moving beyond the Kenyan trials and the study and the scale-up, within World Vision, we've seen PM Plus in the next slide, moving beyond the scale-up, where we now implement PM Plus in DRC, recently with the Ebola response. In Uganda, we are integrating PM Plus or mental health with livelihood, and we are targeting both adolescent mothers from the ages of 16 and above. And then within Nicaragua, in Iraq, we're implementing a full program, which includes MHGAP. It includes up to treatment for severe mental condition or neurological disorder. And then in Syria response, we've used PM Plus for quite a while now. And then Turkey response as well, that is targeting the Syria refugees. Now, beyond World Vision, there is a current trial that is still happening by others, which include actually testing whether PM Plus, by targeting the mother, there is significant evidence for Syrian refugees in Europe, in Turkey, in Jordan, and generally the Syrian refugees, whether there is impact on children. And this study, once it is complete, it will just add more evidence on how effective PM Plus is. Beyond that, World Vision, based on findings from previous studies, we went ahead and targeted men because of gender-based violence in the next slide. A research funded by World Bank and Sexual Violence Research Institute, where we actually targeted men as a means of preventing intimate partner violence. And still, even with a small feasibility sample size in urban Kenya, we still see that Group Problem Management Plus, which included a 6 session that had alcohol, that addressed alcohol and violence perpetration, there was still improved outcomes before, at baseline, and post-treatment, and 3 months follow-up. So I would just like to say we actually saw that there's still improvement if you use PM Plus to target men as a way to reduce intimate partner violence. And recently, late last year, in my next slide, World Vision partnered with Food for the Hungry. And we said, what about including nurturing care groups as a model and integrate PM Plus in the group lessons? We got approval from WHO to be able to adapt the model for nurturing care groups. And we've just finished the write-up of how PM Plus can be used in the nurturing care group, which is an 8-lesson session. And now we are exploring possibilities for a clinical trial to actually check how that works as integration. Now, moving from PM Plus, I want to share my second intervention that World Vision has also tried and others, which is the group interpersonal therapy for groups, which particularly address depression. This is very specific to depression, and most people included for IPT-G have depression screened, and they actually show symptoms of depression at inclusion. This is a group version. It is delivered in session, and World Vision has done a lot of testing for it in Uganda, including as part of the MHGAP, which we have a video for you to watch later on the field experience from the field. And IPT-G, in our next slide, basically it's focused, the original trial World Vision did was an 8 session, but WHO adapted the session to make them shorter and feasible towards 8 sessions of group. And group IPT-G, they're usually 6 to 10 members, depending on the context, and each session could last up to 90 minutes. And it's always important that all the group sessions are the facilitators, who are also trained community facilitators, are paired so that they facilitate the session in 2. And in IPT-G, we have separate groups for men and separate groups for women, just because it's important to address the specific issues that affect women. In the next slide, we see that IPT-G is divided into 3 sessions, where we have a pre-group session where you meet the individual, and the next session is the initial group phase, and then you have the middle phase where now you're doing 2 to 7 group session and a final termination group. And in IPT-G, there is a lot of impact on IPT-G that has been tried, even on education outcomes, because it's a study or it's an intervention that has been there for a long time. Because the original interpersonal therapy for groups was started in high-income countries. So what we had in a low resource setting was an adaptation for us to be able to address depression in low resource setting. And in the next slide, we look at group IPT-G. It focuses on depression and the links between a person's depression and current problems that influence relationships, and finding new ways to deal with these problems. And in the next slide, we see that IPT-G focuses on triggers of interpersonal difficulties, which is one of the most following problems. It looks at death or grief, disagreement and dispute, life changes or role transition, and loneliness and social isolation, which are mostly triggers for depression. Now, we've seen a lot of impact for IPT-G in different settings, including improved school attendance for children, improved productivity, improved sanitation in community, and greater cohesion among community members. And in fact, even reduce conflict in families for those who actually participate in IPT-G. And we've also shared a video for you to be able to look at, basically learn from the field how this has been implemented. Now, I briefly want to go to, as a summary, what do you need to be able to implement IPT-G or PM+? You obviously need training and quality training, which you need a whole full 10 full days of training. World Vision has its own internal curriculums or guidance for training, where we actually ensure that the quality of the training, because all these are lay community facilitators are well trained. And if you're running the training for MHPSS specialists, then you only need maybe 5 days. And it is important that you actually organize the training so that people learn basic skills, and even for professionals, so that they unlearn the clinical world and come into accepting, task shifting mental health from clinical intervention or from the contemporary counseling to actually scalable psychological intervention. And this training includes 2 parts. We have a classroom training, and we also have an in-field training, which is also required, where before you actually get a client, you need to have practice session where the client gives consent that you're going to deliver this intervention as your supervisor watches, or the person mentoring you, to be able to ensure that you actually learn the competency. And currently we say for PM+, if you're training lay community facilitators, it's good you do a face-to-face training. You can train professional psychologists virtually, but it's good they are in one room because there is a lot of role play they have to take in order to practice the skills. And also in field training. Supervision is also a critical component that is in my next slide, that you cannot forget is very critical. You cannot run low and scalable psychological intervention without proper supervision in place, because you need to discuss about the client progress, you need to discuss about the difficulties your helpers or community facilitators are having while delivering the strategy. You need also to manage the dynamics. And most importantly, you need to look after yourself and the care of the helpers. So supervision is very critical because you ensure that the client is protected and your helpers are also protected to more exposure of adversity. And of course, we do know that health happens in the neighborhood, and shifting the focus is the most important thing. From looking to medical to actually upstreaming social determinants of health. And that's why working with faith leaders, proper community mobilization, supporting communities to be able to seek for services, reducing stigma associated to mental health, increasing care for those who actually need intervention, both from the communities or outside, is a key area. So it's just good for us to take a step and say what really works in this context. What are some of the best practices? What opportunities do exist? We do have challenges, of course, amid this intervention, and part of the bigger challenge we experience is the integration and prioritization of mental health in usual work, because you cannot have mental health as a standalone intervention, because if you have it as a standalone, you need basic services to be addressed. You need the stigma to be addressed. So integrating mental health in usual programming should be at the core of every organization or every implementer. And the challenge of working with unpaid, for example, community health workforce or community facilitators continue to pose as a challenge. And workforce development, lack of MHPSS staffing to provide the necessary training and clinical supervision continue to pose a challenge into scale up of psychological intervention. because you need professionals, either one staff in your country, to be able to actually build. But if you have no professional, how are you going to scale up psychological intervention? But one key learning that we've learned in World Vision and even by others is real scale up is feasible, but it demands predictable funding and integration of MHPSS into regular programming so that we can achieve a sustained systemic change. So indeed, it is still possible for us to do, to implement and integrate mental health. We just need to be strategic in how we actually integrate mental health in regular programming. Thank you so much for listening to me, and I hand back over to Paul. Thank you.
Thank you very much, Phiona. A very rich presentation, and I'm going to go right to questions that we'll try to get through as many as possible. We have a little less time. We might be able to go a few minutes over, but let me just bring a few to your attention so that you might be able to address them. There is Joseph Escaton from Turkana, Kenya, who's director of Christ Mission Foundation, and he's asking about working with pastoralist communities where young girls at the age of 10 to 12 get married, and he wants to know about early marriage, whether this can cause mental health issues, and if so, what are the strategies or mechanisms to bridge the gap or deal with them?
Yes, indeed, early marriage or any source of abuse for any child basically put significant risks of mental health to both the child who is getting married and her future children. There are various interventions that can actually be able to be addressed depending on whether you are already working to a child you've rescued from early marriage or whether you're supporting a child who is in a current marriage. So there are various interventions that you can actually implement to be able to protect the child. And of course, the first thing is that you need to rescue the child from marriage, because we all know that is abuse. So the first thing is rescue the child and have the child basic needs met, and as well as psychosocial needs are met. And this would mean you may want to link the child to help or a targeted intervention as you restore the rest of the relationship with parents or with family.
Thank you. Let me go on so you can answer as many of these as possible. Some excellent questions. This person asks, I belong to a smaller organization and we do programs in several countries with pregnant moms and children under 2. If we wanted to incorporate PM+, would we be able to get materials and or training somehow? This is a person from Medical Ambassadors International. So how would they get access to these kinds of materials?
Okay, first, access to PM+ materials or IPT-G materials, they are accessible at WHO website. If you Google, you can get all the generic manuals. But if you need the training guides, they have not yet been published, and you can always email me and I can share with you all the necessary materials. However, for PM+, particularly, we have not found it feasible for young children, because it is an intervention for adults. And primarily, it does not address the concern of children. And maybe if you're looking at children or young mothers, if you're looking at young mothers' depression, but also cautious with the age. So if this is something you'd like to learn better, maybe when I understand your current population, I can be able to link you to the relevant intervention that may be feasible, because it's not a one-fit intervention for everything.
Thank you. Let me give you another question. This person appreciates the presentation and wants to know about how World Vision adapts PM+ to be responsive to local, cultural, and religious contexts. This work might be different, for example, in Syria versus Uganda. And is there adaptation for context, cultural, religion in other tools like IPT or the gender-based violence work?
Yes, indeed, the first thing we do normally is adaptations of tools. And you will find that the way we implement PM Plus in different contexts is totally different, just because we respect the cultures and the values that people hold in different countries. So you'll not find us adapting the same way. And even the training, at times the training guides are adapted depending on the context, which is done jointly by our World Vision staff in country and also representative from the community.
Thank you. I'm looking, okay, let me see. One person wants to know, well, what are the main causes of mental health disorders?
There are many causes and they can vary from early childhood traumas. They could be biological. They could be caused by just exposure to distress. For example, if you've lived in a community that is experiencing violence, your situation has changed. This has exposed you to adversity. And we just know, like, based on our discussion today, gender-based violence is one of the biggest major actually public health concern when it comes to mental health disorders. So it could be biological, it could be environmental, it could be the exposure of the environment where you're living with. So it really depends on individual. And not every individual who is living in conflict-affected regions experience a mental health disorder, because we only know it's only about 9% of those. Some people overcome adversity even without treatment, but some do not overcome adversity when they are exposed to. So not everybody that live in conflict area has a mental condition.
Another question that might follow closely on that is, have you or could you train pastors to identify cases or depression or other mental problems and refer them or help address them in collaboration with health professionals? Also, leaders of women's organizations in churches.
Yeah, so how we train in World Vision is we only train in the space where there is comprehensive programming, because we do not want to clinically diagnose people and do nothing. So our approach is where we build the capacity of a pastor, for example, psychological first aid. It gives them ideas on how to serve in a humane way. If somebody is overwhelmed by crime, do you just pray for the person, or how do you manage somebody who is extremely distressed at the moment? What is the ethical way of you to do that? And of course, how do you effectively refer? And we know the biggest challenge with referral is there is no referral in most settings. You refer someone, but they don't get help. So we go further to ensure an enhanced referral mechanism. So other than teaching or training faith leaders to just diagnose people, but we actually offer them like PM Plus. If somebody is diagnosed, you've run a patient health questionnaire and their depressing symptoms are high, maybe include them in problem management class and take them through, or include them in an interpersonal therapy for group session. So that would be more helpful, because they are not just referring people to nowhere. So it is possible to train faith leaders, but not just to diagnose, but to manage the condition.
Thank you. I think we have time for one more question before we close. And I'm looking at this, and this person's asking about, based on your presentation, you identified a number of countries where these interventions have been scaled to. And in this case, were these done through World Vision, or were there World Vision trainers in each country, or are these done through other organizations?
So particularly the ones I have mentioned today, we've done the examples I've given is World Vision and Ministry of Health. So the Ministry of Health is in charge to integrate it. And other organizations, for IPT-G, it's the same. It was WHO, Ministry of Health. In other settings, like in Turkey, we partner with local organizations. So it's not purely World Vision. So it's World Vision and its partners or Ministry of Health or government.
Thank you. Because of time, we're not going to be able to answer every single question. I feel like this webinar is more of the start of a conversation, and for many of us, it might be even like a whole new area that we haven't even thought about. So I welcome you to share this. This webinar will be available on YouTube, and there will be a link provided in the, I think in the chat or the Q&A box. And if you have more interest or would like more information, please feel free to contact us at CCIH about this. And we would be happy to continue to engage you in this conversation. I'm going to ask Phiona for any closing thoughts before we close. Any final words?
Just to mention that as one of someone has asked, partnership is very key, because as a single organization, you cannot do all this work. It's feasible, but it's also good to create partnership both with communities and also with local partners who have maybe greater grassroots presence to be able to implement. And integration is definitely key in all aspects of programming. Thank you.
Thank you very much. We hope that participants have enjoyed this session. CCIH would like to hear your thoughts on the webinar, and we'll be following up to get your opinions on how it went in a survey that will be emailed to you. So if you signed up for this, you'll be receiving an email for a survey. And please, we ask you to fill it out so that we can continue to improve. It also gives us ideas for future webinar topics that might be most interesting and helpful to you. With that, I'm going to take the opportunity to thank Phiona a last time, and I'll close this in prayer. Lord God, I thank you for the workers in your vineyard. I thank you for many people like Phiona who really are committed to seeing, to bringing your kingdom here on earth through their work, especially in caring for the most vulnerable. And we think of mothers and children. And we just all want to feel a deep passion for the concern of the needy, as even our Lord Jesus did. And all of us who have met together, I pray that we will have been inspired by this and would seek to continue this very important work and to feel your presence, the guiding of your spirit in what we do. We pray these things in Jesus' name. Amen. Thank you, everybody.
Thank you.